summarize to you the guidelines, the ABC guidelines for the specific subtype of breast cancer, ER positive, HER2 negative. And then I'll also finalize with some more general comments about the advanced breast cancer and an organization that it's called ABC Global Alliance. So these are my disclosures. And let's start by discussing that these types of tumors, so what we sometimes call luminal-like tumors, are very heterogeneous, and this has implications for our therapeutic decisions. So we have some heterogeneity for the patient, have different ages, different menopausal status. Probably in the future, we will be using more pharmacogenomics, but we also use genetics, as you know, and very importantly, patients' preferences that are specifically important since we are talking about an incurable disease. We also have heterogeneity from the disease presentation. We sometimes have a visceral crisis, and I'll come back to this, or visceral metastasis, bone-only disease, etc. And we have also some heterogeneity regarding biology. And I'll go a little bit further on this. So these tumors are considered and are known to have certain alterations, the most important or most frequent ones being the ones related to the PIK3CA gene. And this happens both in the so-called luminal A and luminal B. And there is also some alteration called ESR1, and these are the mutations of the estrogen receptor that have been linked to resistance to aromatase inhibitors. However, these mutations are not yet ready for us to use in clinical practice. So from all these biomarkers, what we can use is mostly the estrogen receptor, and we don't have a good biomarker to tell us if we should use tamoxifen or fulvestrant or an aromatase inhibitor. Also, for many of the other agents that we use in this subtype, we do not have a biomarker, with the exception of the PIK3CA inhibitors that I'll come back to that. So if we do not have biomarkers for the different endocrine therapies and also the targeted agents that we sometimes combine, such as the CDK4/6 or the mTOR inhibitors, we only have a biomarker for the PIK3CA inhibitors called ALPLICID. So how can we decide? So let's simplify this heterogeneity and divide this very large group of patients. Remember that these are about 65% to 70% of breast cancer patients. We can divide in three main groups. One that has what we call a visceral crisis, and I'll detail for you what this is. But this is at most 15% of these patients. And then we have a group of patients that we can consider as having a more indolent disease, low burden of disease, less aggressive biology, for example, very long time of interval between the end of adjuvant endocrine therapy and the appearance of metastases. And then we have a very big group that are all the other patients. And I'll come back to this diagram to tell you what to do in each of these. So how do we approach a patient with this type of disease? These are the questions you should ask yourself. Do I need chemotherapy? And the answer is rarely you will need chemotherapy to start treating these patients. If I go for endocrine therapy, what is the best agent? Can I use endocrine therapy alone, or should I combine with the targeted agent? And if I go for chemotherapy, what type of chemotherapy should I use? So this is the algorithm of ABC5 that you can find freely online, together with the paper, both at the ESMO website and at the ABC website. And you see that there are many options. This is a subtype where we do have many options. Some are more expensive than others, and I'll go through that with you. But there are others that are not very expensive. And at the left side, you see all the endocrine-based therapies, which are the preferred options. And on the right side, the chemotherapy-based options. One point before I go into the details, and I think very important for your region of the world, where you have a high proportion of young women having metastatic disease. Many trials in this setting have not included premenopausal women, and this is something we have been fighting to avoid. So the first recommendation for a young woman with advanced breast cancer is to induce menopause, to do an ovarian suppression or ablation. So from that moment on, she should be treated as a postmenopausal woman. And these women should not be excluded from trials. And we've been fighting for this for a while. And I'm very happy to tell you that the FDA has listened, and they are now defining this guidance for clinical trials to avoid exclusion of young women from trials. Now, how can we make sure that these women have an adequate ovarian function suppression? So the way you do the suppression or ablation is either through surgery or through an LHRH agonist. You can also do it with radiation, but it is not always effective, and it is a technique that we do not recommend. We prefer not to use it. So if we use an LHRH agonist for these young women, we should usually use it every 4 weeks instead of every 3 months. And we must also confirm that the ovarian suppression is in place with some serial evaluations of estradiol, particularly if you want to give an AI. And this is one of the take-home messages of my talk. So if you want to give an aromatase inhibitor to a young woman, first you need to induce menopause, and you need to be certain that she is menopausal. Only after that you can start the aromatase inhibitor. Otherwise, the aromatase inhibitor will have the reverse effect. So aromatase inhibitors are used in fertility treatments. So they are used to stimulate the ovarian function. In young women, that's how they work. So you must first be sure that the ovarian function is suppressed before you give an aromatase inhibitor. And then moving to the specific recommendations for this subtype of breast cancer, please remember that endocrine-based therapy, and again endocrine-based therapy, and again endocrine-based therapy is your option and your choice, much more than just going for chemotherapy. The only reason to go for chemotherapy is if you have no response at all with the endocrine-based therapy, or if you are out of options from the endocrine-based therapy, and then you can and should go for chemotherapy. And this applies to postmenopausal women, premenopausal women, and also to men with breast cancer. So a little bit of definition of what is a visceral crisis. So visceral crisis is not equal to having visceral metastasis. So just because you have some liver metastasis, that is not an indication for chemotherapy. Please remember that. That's also one of the important take-home messages from my talk. And for you to have a visceral crisis, the organ must be severely compromised. So for example, for us to consider a liver visceral crisis, you need not just to have visceral metastasis, and not just to have an increase in transaminases, but you need to have an increased bilirubin of 1.5 times upper normal limit in the absence of an obstruction. If there is an obstruction, you take care of the obstruction first, and then you see what happens to the bilirubin. The same in the lung. So just because you have multiple lung metastases, that is not a visceral crisis. And if there is a pleural effusion, first you take care of the pleural effusion, you drain it, and only if there is dyspnea, so shortness of breath at rest, after you have drained the pleural effusion, that you consider a visceral crisis. So how do we choose the endocrine agent? The most important factor for the breast cancers that are not de novo, that are recurrent, is what have you used in the adjuvant setting and for how long. So let's say that you take someone who has been on an aromatase inhibitor for 5 years. My preferred first agent at relapse is not an aromatase inhibitor. It will be either tamoxifen or fulvestrant. But for someone who has received tamoxifen, first option is an aromatase inhibitor. And for those who have de novo disease, you have this trial called Falcon that compare in de novo metastatic disease, fulvestrant and an AI. And you see that there are no major differences, just a small 3 months difference in favor of fulvestrant. And no other major difference, so we can use any of it. Then there was a finding, a subgroup analysis finding, that seemed to indicate that fulvestrant works particularly well in bone disease. So it does not mean that it doesn't work in visceral disease, it does. As you see in the bottom right, the graphic that shows the effect on visceral diseases, fulvestrant and an aromatase inhibitor have the same efficacy. But in bone, fulvestrant works a little bit better. I, in the beginning, thought that this was not true. There was just a chance finding. But the fact is that we see this reproduced in other trials. For example, in a trial with a CDK4/6 inhibitor, if you see in the bone-only disease, the fulvestrant alone has a very powerful effect. So maybe there is a reason, and we have to go back to basic research to try to understand why. Now, when and if you can use a CDK4/6 inhibitor, does it make a difference if you use it with fulvestrant or with an aromatase inhibitor? This was the question answered by Parsifal study. And what you see is no major difference also. So even if you're going to combine with a CDK4/6 inhibitor, you can use either letrozole or fulvestrant. So the most important factor is what has the patient received previously. So moving forward we have chosen now the endocrine therapy agent. If we have access, and this is depending on economic factors, unfortunately, if we have the option and access, CDK4/6 inhibitors have become the standard of care in combination with endocrine therapy. And we can combine it with an AI or with fulvestrant. We can use it in de novo or recurrent advanced breast cancer, in first line or second line, for primary or secondary resistance. We can also combine with tamoxifen. The only exception is ribociclib, which you cannot combine with tamoxifen because there is an interaction and there is an increase in prolongation of Q2C, so a cardiac side effect. Why are CDK4/6 considered the standard? This is a summary of the efficacy findings in the different trials in the first-line setting, and you can see that all of them have provided a benefit in progression-free survival between 10 and 14 months compared with endocrine therapy alone. And also we have the results for ribociclib in 2 studies, and we show the results for overall survival, and they show a relative reduction of 30%. We still don't know the magnitude of the absolute benefit, but it should be something between 6 and 9 months. So there is a benefit in overall survival, And I would like to remind you that there is no chemotherapy that provides such an overall survival benefit. And they do have a good impact in quality of life. Either they do not change, so they don't make it worse, or in the Mona Lisa 7, there was an improvement in the quality of life. So this is the reason why they've became the standard. Now, should we use them in first line or second line? So the majority of the experts in ABC said if they could, they would use it in the first line setting for most of the patients, not all, but most. If we use it in second line, do we still have an efficacy? Yes, this is the summary of the trials. They provide around 7 months benefit in progression-free survival and the same relative reduction of 30% in risk of death. And that translates in a benefit of about 9 months in overall survival, which is very important because this disease has a median survival of 3 years. So here you are adding almost an additional year. This was stronger with abemaciclib and ribociclib, not so much with palbociclib, but probably because the trial, the Paloma 3 trial, was not sufficiently powered to detect a statistical significant difference. Again, no chemotherapy in second line provides such an overall survival benefit. In terms of quality of life, the same conclusion. It either improves or does not have a negative effect. So this has led for the very high classification of these agents in what is called the ESMO magnitude of clinical benefit scale, that I can in the discussion, if you want, explain a little bit better what it is, but it's an objective scale to classify the benefit of agents and help you fight for reimbursement. So these agents are classified between a 3, 4, and one of them as a 5, which is the top score in this scale. What is the problem of these agents is cost. The cost that you see there is the cost in my country. It can be different in other countries, but gives you a perspective that these are expensive treatments and drugs, and this is a major limitation in their implementation. How do they compare with chemotherapy? Some trials have already been reported, others are ongoing, and they seem to compare quite well in terms of efficacy and also in terms of toxicity. So coming back to my graphic dividing these patients in 3 main groups, what you can see is that for the visceral crisis, which is only about 15%, chemotherapy should or may be indicated. For this subgroup of also about 15%, less burden, less aggressive disease, you can use endocrine therapy alone. And for all the others, if you have access, what is recommended is endocrine therapy and the CDK4/6 inhibitor. But please, in your setting, if you do not have access to CDK4/6, your second best option is endocrine therapy and not chemotherapy. Now let's move for options in the second line setting very quickly. So what we have here, we have other targeted agents that we can combine with endocrine therapy. One of them is an mTOR inhibitor called Everolimus. This agent provides a very good progression-free survival benefit. If you see, it's more or less the same benefit of the use of a CDK4/6 in second line. So this is a second line study. But the trial was not powered, sufficiently powered, to see the survival difference. So we do not have a proof that it improves survival. It was also studied in the first line setting, but in a non-randomized trial. So the data we have points out that we should first, if we have access, use the CDK4/6 inhibitors. Also, Everolimus is costly, a little bit less, but still costly. And we also have data in premenopausal women. So this is the recommendation of ABC, is that we can use Everolimus for those that were previously exposed to CDK4/6, or if you do not have access to CDK4/6, and that we can combine this with an AI, with tamoxifen, or with fulvestrant, and that we should pay attention to the side effects. Everolimus has a bad reputation. However, the worst side effect is mucositis. And this mucositis can be prevented by the use of a mouthwash with steroids. And since we have been using this, we almost don't see mucositis or very mild mucositis. So this is very, very important to use these mouthwashes as prevention. What else do we have here? We have a new agent called ALPLICID, which is an inhibitor of PIK3CA and acts in tumors that are PIK3CA mutant. Now, this was studied in the SOLAR-1 study. In these patients, in this trial, it's important to know that very few patients, only 20, had been previously exposed to a CDK4/6 inhibitor. In terms of PFS, we see more or less a 5.5 months benefit, similar to what you see with the CDK4/6 in second line, not in first line, in second line. Do we have an overall survival benefit? Unfortunately, again, the trial was not sufficiently powered. There is a numeric difference, but it's not statistically significant because they didn't power the trial for that. And very important to pay attention, this is a very toxic drug. And I would like you also to learn so that you can be critical. The best way to see if a drug is very toxic is in the percentage of dose adjustments. So how many patients had to reduce the dose or stop the treatment for a while? So how many adjustments did you have in the doses and the treatment exposure? And if you look at the graphic on the bottom, you see that in the arms of ALPLICID, it's between 70% or 75%. So a very, very high number of patients have to have a dose adjustments. And this is the clear indication that a drug is very toxic. And there are some toxicities that occur here, like hyperglycemia, rash, and GI toxicity. ALPLICID is also expensive. So again, this is a limitation to its use. So can we use it after a CDK4/6? We have a phase 2 trial that has looked into that. Can we retain the efficacy of ALPLICID after a CDK4/6? And also in premenopausal women, pre and post. So here, although it's non-randomized, we just wanted to see if it retains its efficacy. And you can see that both the response rate and the median PFS are similar to the SOLAR-1 trial, so saying that it does retain its efficacy after a CDK4/6. So conclusions about ALPLICID: education of patients regarding the side effect, prophylaxis with antihistaminics, steroid mouthwash, monitoring, specifically monitoring glycemia, very, very careful in diabetic patients, also very careful in elderly patients. And at our current knowledge, the preferred first line treatment is endocrine therapy CDK4/6, independent of the PIK3CA status. And where you have access to the test and to the drug, your preferred second line would be endocrine therapy ALPLICID if there is a mutation in PIK3CA, or endocrine therapy Everolimus if there is no mutation. And what is the best sequence for the individual patient is still something we do not know. And we have a major problem with the way that EMA has approved this drug, because it says that it's approved only after endocrine therapy alone, which is problematic. So this is the ABC guideline recommendation for ALPLICID. It's one treatment option, not a standard of care, but a one treatment option, particularly to give after a CDK4/6 inhibitor. These are recommendations that you can read then carefully regarding how to manage hyperglycemia, hyperlipidemia, and also the rash. What to do next? So there are other options to keep on the endocrine therapy options. And you have here a list of several options for if you do not have access to all these expensive agents, and that you can use in both first and second line. The main take-home message is that you should use several lines of endocrine therapy before going for chemotherapy, and that you should provide the same options to premenopausal women and to men as you do for postmenopausal women. So let's very briefly say a few words about the chemotherapy options on the right side of the algorithm. Most important take-home message is that there is very, very rarely an indication to do a combination chemotherapy. It does not provide a benefit. And I see this very, very often. So use one agent at a time. Sequential monotherapy provides you the same efficacy and provides much less toxicity. So we have here a meta-analysis looking into many types of chemotherapy, and you see that there is no benefit for the combination, not PF nor in overall survival. For how long should we use each regimen? So this should be tailored to the individual patient, particularly to toxicity. So usually we say we give it until progression or unacceptable toxicity, but please make sure that this unacceptable toxicity is defined by the patient and not by the physician alone. And a couple of take-home messages regarding chemotherapy use. So in an incurable setting, we want to treat for as long as possible with a good quality of life. And I've told you during the talk that no chemotherapy provides a substantial overall survival benefit, none of it. So we have to be careful and when we choose, and we should choose based on the toxicity profile. So for some patients, they don't want to lose their hair. For other patients, they don't want to have neuropathy if they need their hands to work. So discuss the side effects with the patient to find what is the best option. Do not be afraid to reduce the dose. The idea that we must keep the high dose like we do in the early setting, this is not needed for the metastatic setting. We do not need to retain the highest dose. And it's better to reduce and find what is the best dose for that individual patient than be forced to do many interruptions. And a very good example is capecitabine. You do not need to use neither the dose that is registered, not even most of the time, the 2000 milligrams per square meter. You should adjust until you have almost no hand-foot syndrome, and that's the good dose for that patient. Also prefer oral drugs. They are more convenient, cost-effective, allow the patient to keep on working, and again, discuss the patient preferences. This is a review that you can have a look if you want regarding the strengths and weaknesses of oral chemotherapy, and that makes it the preferred route of administration for metastatic patients. And way of giving oral chemotherapy is using metronomic chemotherapy. So low doses on a daily schedule or a weekly basis. The most frequently used is cyclophosphamide and methotrexate, very inexpensive, very good efficacy in all subtypes, including triple negative. Capecitabine can also be used metronomically as well as oral vinorelbine. And now in the next 3 minutes to finalize my talk, I just want to share with you some additional important facts about advanced breast cancer. So we always talk about treatment, and we forget that for these patients, supportive and palliative care is crucial, and it has to be there from the beginning. Supportive care is what allows you to give the appropriate treatment. So management, we have talked about management of the side effects, prophylaxis of mucositis, management of GI symptoms, diarrhea, nausea, vomiting. All that is extremely important so that the treatment is tolerable. And palliative care should start very early on. It's not terminal care, it's palliative care that includes a control of pain, control of shortness of breath, control of difficult symptoms. And the access to effective pain treatment, including morphine, that is not expensive at all. It's something that we all must fight together. And when we talk about disparities, disparities in your area of the world are very important, you see that it's not just the expensive medicines. There are disparities in pathology, and without pathology, you cannot treat well cancer. Disparities in access to radiation, crucial to treat metastatic disease, to treat brain metastases, bone metastases, and many others. Sometimes it's shortness in medicines that are not expensive at all. And there you see on top, the graphic of the world according to usage of morphine. And this is, I think it's a very shameful map, because you see that the poorest regions of the world, patients don't have access to morphine. And this leads to this other graphic that it's terrible. And this shows percentage of patients that die in pain. So we are talking about an incurable disease. So unfortunately, all patients would eventually die, but they don't need to die in pain, and they do not need to die in suffering. And that's why I wanted to remind you that this is the most important thing we can provide to our advanced breast cancer patients. And this is one of the things that our organization is fighting for. The ABC Global Alliance was created together with the conference and the guidelines, but it's now an independent organization that has members all over the world to fight for these patients and to share resources. So you please go to the website. There are many resources and many programs that you can have access to free of charge. And we have defined the goals that we are fighting for all over the world. Rich countries, low middle income countries, these are the goals to fight for these patients. And one of these goals is about stigma. And because of stigma being such an important problem all over the world, it doesn't matter which type of country, I wanted to end my talk by sharing with you, I hope the technology helps me, I would like to share a very brief film of 1.5 minutes where the patients that have advanced breast cancer share their stories with you. And I hope this functions and that let's try.
It sometimes feels like a price is being put on our life, and that isn't right.
They just look at you as a walking corpse.
You know, I am living probably their worst nightmare.
It is treated like a curse.
They can't understand that there's no happy ending, no getting better.
No, let's not use the money for treatment because she's gonna die anyway.
Thinking about my kids is difficult.
I am
Advanced
Breast cancer.
I hope that you were able to hear the sound of the video, and I'll finalize by inviting you all to attend the ABC6 that will take place this year in November. Hopefully face to face. If not, if COVID doesn't let us, we will do it also virtually. Thank you very much for your attention. I'm happy to take any questions.